Thank you very much. I want to thank Vincent for inviting me. Now, for this presentation, we based ourselves on recent guidelines published in 2023 in the US and in Italy and in the UK. And there is really a lot of information and advice. Now, who should we operate on and when? Surgery comes in second line of treatment for failure of medical treatment or in case of a recurrent fissure. Of course, it's first line if you've got an infection or if it's very painful. Now, what do we have? Well, I will start with lateral internal sphincterotomy. The idea is to decrease hypertonia, so we are going to cut the internal sphincter all the way to the line or to the apex of the fissure. It's called Taylor sphincterotomy. We do this laterally in order to minimize the risk of getting a keyhole deformation. The benefits is that it's an easy follow-up, no post-op care, but the risk is that you have a risk of fecal incontinence. It's not a standardized procedure, so how to do it? Then there's fissurectomy, with or without anoplasty. The objective is to regenerate better quality tissue. So we're going to cut the sides and take on the annexes. It spares the sphincter. You can carry out a histological analysis. You do this with or without anoplasty. You cover the fissure area or the wound with a skin or mucosa flap. Benefits: you remove all the annexes. You can send a sample for histological analysis, and there's no risk of incontinence. But there are a certain number of post-op constraints. Practically, do you want to go for anoplasty or not? After that, now, which treatment to choose? It's not all black or white. I tend to prefer fissurectomy, and I will tell you why. Now, the LIS, lateral internal sphincterectomy, it works. It's equivalent to nifedipine, which is much less invasive, of course, but there's less recurrence. This study found fecal incontinence at 12%. Now, compared to botulinum toxin, here it's kind of in between the medical treatment and surgery. So LIS is a little bit more efficient. There's less recurrence. You have the same rate of complications, but you've got more fecal incontinence. Now, once we've said that, how do we do this? In the US, they want to go for open or closed technique, which are equivalent, but closed sphincterectomy is less painful. And also, how do you do it? Well, tailored sphincterotomy, which goes all the way to the apex, is not only giving similar results in terms of healing, but also it decreases the rate of incontinence. So you really want to use this tailored sphincterotomy, because you see that in this study you are at 10% for the conventional procedure and 2% for tailored sphincterotomy. So there is really a non-negligible difference. Now, the main question for me is how to select the patients. In the UK, they really insist on this. They say for female patients, you need to do this with a lot of precautions. Also, for patients who have anal sex, you have to adapt to the patients and to make sure that you identify the right indication. Now, I would summarize indications for LIS as follows. It has to be done mostly in men. I would not perform that on a woman. It has to be very hypertonic, very painful. You feel that the patients will have difficulties in post-op care. You don't want to have an infection. No continence disorders. Because, you know, the 25-year-old woman who doesn't want to stop work, I would not... of course, she will not be incontinent right away, but after 3 kids and 3 deliveries, maybe there will be this factor of fecal incontinence. So for me, it has to be mostly performed on men. Now, where do we place fissurectomy in all this? Well, lateral internal sphincterectomy asks a lot of questions. First of all, we talk about hypertonia, but how do you hypertonus? How do you assess that? And then you have guidelines in the UK and in Italy. They talk about manometry, but how do you do this on a hyperalgic patient? Maybe fissurectomy is going to decrease anal pressure. Of course, histology, we've discussed that already. And international literature seems to be more in favor of LIS, but what about the French experience? And I think that the key question is why cut a muscle that we really try to spare, especially when you talk about fistulas. So, does fissurectomy decrease hypertonus? Well, yes, you have patients who are very tonic, and it decreases after 12 months. They still have less hypertonus than before surgery. Now, annexes, there are a certain number of them here. As you can see, 90% of the patients have skin tags or hypertrophied papillae, which are going to be a problem. In that case, LIS is not beneficial. Now, does it work? This is a study that you have a lot of studies or trials in foreign literature that look at fissurectomy plus flap. It's called skin anoplasty. And you see here in this meta-analysis, you see that, or literature review, you see that the rates are similar, but the risk of fecal incontinence is higher, which is not a surprise after sphincterectomy. And this one is interesting because it has a 21-month follow-up retrospective with 50 patients in every group, and it shows here that the flap is better than the LIS, almost 90% healing, and fecal incontinence was reduced. Here they have 17% fecal incontinence, which is a lot, but you still have the same trend actually in all the groups. Now, what did they say in the US? Well, they say that the flap is a safe surgical alternative with a low risk of fecal incontinence and comparable healing rates. Now you're going to say, we don't do a lot of flaps in France. Yes, of course, but what about our experience in that area? Well, there's an interesting study by Zetoun. He looked at 50 patients who had fissurectomy, 94% scarring, complete healing after 10 weeks. And this is another study with our department, our ward, which wanted to look at the potential benefits of anoplasty. You see that the healing is the same, 2 months, 96% healing, and no difference in fecal incontinence between the two groups. And also, we didn't identify any benefits for anoplasty. This is a study by Abramovitz. It's interesting because it's a little bit more moderate. The patients healed in about 2 months, no recurrence. But they looked at Veze and Wexner scores. They did find a little bit of fecal incontinence after surgery. The difference is a little bit higher, but it's really minimal actually. So I think that the message from this study is that all patients with fecal incontinence or fecal incontinence risk, we need to have measured and properly indicated surgery. Now, what's interesting with fissurectomy is that it's not the only thing you can do. You can combine it with other treatments. For example, dutilasem or botulinum toxin. You have a study here on Botox, which is really interesting, with a 81% healing rate, 6% recurrence, and 1% incontinence. Knowing that fecal incontinence with Botox is transient. It disappears after 6 months. So here's my algorithm. You always start with medical treatment. In case of a failure or pain, you have to look for infection. If there's no infection, You look at the risk of fecal incontinence. If there is no, and if it's a man, because if it's a woman, I would not go for it. But if it's a man, you can go for LIS. If you have risk of anal incontinence, or everything that I told you about, you are going to go for fissurectomy. I think that what's important is to inform the patient, to explain all the techniques to them, the constraints of and risks, and it's always a discussion that you need to have with the patient. Thank you for your attention. Thank you. We have time to take one or two quick questions. If we don't have questions in the room, there's one in the chat about LIS. How can you assess the amount that you have to cut, the amount of sphincter that you have to cut? Does it depend on the prolapsus, or should it be 30 to 50%? Well, it's general anesthesia, so you cannot really assess the sphincter tone. So I think you have to stick to tailored sphincterotomy. You need to look at the size and the height of the apex. And really, you need to go for a little incision, closed incision probably. Manometric studies have shown that if you are at less than 25%, which is more or less what was said, of resection, the hypotonia in post-op will be less. So I think that's pretty much what you have to have in mind. Okay, thank you very much.